visiting us. Well, the clinic is not pretty, but it's workable. So we treat a lot of patients there. Average of like one day is like 500 to 600 patients, eye patients. And Friday is slightly easier, it's like around 300 to 400. And 50 injections of vitamin B2 injections per day. So anyway, it's a pleasure to talk after Professor Adrian Cole, because he covered some of my topics already. I'm going to show you the masquerades of wet AMD, which is, I think, very important. You may see this disease more often than you thought if you try to look at it. I'm going to show you this is a case representation. A 69-year-old man, progressive blurry vision in his right eye for 2 years. Visual acuity in his right eye is 20/40 and left eye is 20/20. After examination, unremarkable. And here's his picture. This is back 2 years ago. This is back in 2011. Visual acuity is still 20/20. You're gonna see something around here, right, at the back. This is 20/20. This is right eye. And this is the other eye, the left eye, 20/20 as well. You think the thing in the right eye and the left eye is different? You think are they different or the same thing? Are they different or the same thing? They're different. You say this is the same thing? Both eyes? Actually, this stuff is above the RPE, right? Here. And this is under the RPE, right? So this probably be just lucid. Sorry, the color photo is not as clear. And we follow this patient, since the patient had 20/20 vision, so we follow them. This is a year later. The yellow stuff here, I mean the hyperrefractivity stuff above the RPE is kind of increased in terms of amount, right? And you can see like yellow stuff here at the macula. It's corresponded to these some retinal stuff, right? That's the right eye. The left eye is still the same. And here's like a year later. This is 2 years after we followed. You can see the increased amount of subretinal fluid. Yeah. But, well, visual acuity is kind of slightly decreasing. You want to do something at this point? You want to do something? Watch, right? Yeah, okay, well, visual acuity is not too bad. It's 20/25. So the original doctor would like to observe him because it's, well, there's something changed there, but this is 3 months later. 3 months later, the subretinal fluid kind of increasing, and some internal fluid as well. And there's some, maybe we call it maybe a dripping of the photoreceptor cells, maybe. So, and you can see there's some changes in the internal fundus as well. 20/40 now. What are you going to do? It's probably be like something fluid, right? Right. So you think this is wet AMD? Likely. Slightly. This is the other eye. The other eye is still okay. Yeah, this is the angiogram. This is the FA. And this is the ICG. Is that the leakage? Or the FA? Right? But the ICG shows nothing. There's nothing. There's no any hyperfluorescence. Actually, it's hypofluorescence at the macula, the ICG. And this is the left face. There's definitely leakage in the FA, right? Because, well, in terms of leakage, it's kind of hyperfluorescence, and the amounts kind of keep increasing. This is by definition, right? And you can see the border is kind of blurred. it's indicated that this is kind of like maybe a fluid which is leak from somewhere. So you think this is a point that you can like start the treatment? And what kind of treatment you want to start? Jeff, something else. You want to do the PDT?
No.
So what is the tentative diagnosis at this point?
Type 1, type 2.
The other eyes, okay. What is tentative diagnosis? And you're gonna, initiate treatment based on the diagnosis, right? So the interior doctors think this is a wet AMD. So I think it's close enough, right? Because from the angiogram, you see the leakage there. And it's kind of, he followed this patient for a while, and there's an increasing of the fluid, right? So we decided to treat this patient with what? Anti-VEGF, okay. The initial doctor treat this patient with ranibizumab for 3 monthly injections, and then here's after 3 injections.
Any drug history?
What?
Any drug history?
Any what?
Drug history? Any medicines he's taking?
No. Why do you ask? Why do you ask?
Thinking of any drug toxicity presenting in blood vessels over the period of time, accumulating and causing changes like that.
Yeah, maybe kind of drug related fluid, right? Yeah, no. This is the angiogram after 3 anti-VEGF injections. Still the same. Still the same, right? Still the same. Still the same. So what you gonna do? Say. So what's the next steps that you're gonna do? You want to this is ranibizumab injections. You want to switch to some others, like aflibercept. You want to switch to aflibercept, right? So may I get a vote here? So what you want to do for this patient? How many of you want to switch anti-VEGF? How many of you want to put PDT in these patients? Or maybe combine PDT or observation? Or look back at the initial diagnosis? Many of you not. So yeah. So instead of you change your treatment, just like Adrian told you, instead of if you decide to switch, you have to think about it very much, right? You don't want to change horses doing the right. So you better look at to your initial diagnosis, whether or not this is a wet AMD or not. And actually, it is not wet AMD. What do you think about it? Yeah, probably best disease. What's that?
Adult onset vitelliform dystrophy.
Vitelliform dystrophy. You say what? Vitelliform dystrophy?
For that, we need autofluorescence.
Yeah, okay. Good. Yeah. So sometimes, since this patient has kind of yellowish lesion at the macula, anytime you see the, going back, here, you see this yellowish lesion, and I think what's very nice about this case, which I like a lot, because you can see this patient from the beginning. Yeah, since he has only 2 bumps of this yellowing stuff at the beginning, and you have no fluid at all. Actually, it's not fluid. I'm going to tell you later what the halo area is. You see, this is very nice that you can follow this patient for some time. So, well, somebody call this is adult macular vitelliform degeneration. But if you search the literature, you may see something which is called adult vitelliform macular degeneration. Some authors saying that, and some may call this pseudo vitelliform macular degeneration. So these authors, they don't want to use the term vitelliform, they just put the term pseudo vitelliform to this disease. But some authors say this is a kind of dystrophy. They call it adult foveomacular vitelliform dystrophy. And some say this is adult vitelliform macular dystrophy. Or equine, it's not adult, for this author, it's not adult, but it's equine vitelliform lesions. So, which one you want to believe or you want to use? Actually, they're the same thing. They're the same thing. They talk about the kind of masquerades of wet AMD in adult patients that have this kind of yellow stuff at the macula. And sometimes it seems like they have fluid. You have to be careful whenever you see this yellow stuff and you see fluid on the OCT. It may not be wet AMD. If you can recognize this condition from the beginning, you may not want to inject anti-VEGF at the beginning. But in some cases, they may be associated with neovascularization as well. So you need to take a look carefully. However, so for this patient, after 3 randomized injections, and we take a look back, this was referred back to me, and we decided to stop anti-VEGF injections, and we just keep watching this patient because visual acuity is not too bad. It's 20/40, and this is after 3 injections already. So we decided to just keep watching this patient. And here, this is 2 years after we keep watching this patient. Well, the yellow materials kind of disappear from the macula. And here, and the OCT, well, visual acuity is 20/20 now, and everything is, there's no bumpy material above the RPE, and there's no fluid at all. So this is a happy ending. However, you're going to see some cases of this in your practice, but you need to keep in mind about this condition. It's like this. This is another case. You see this kind of yellow material at the center of this patient. Well, you're not going to see anything much from the infrared imaging. But if you do the OCT, you're going to see the halo. Looks like subneural fluid over here. And this is inferior, right? And you can see this kind of yellow stuff trying to be at the inferior part of the lesion, but sometimes it can be like at the temporal part as well. But usually you see at the inferior part. This is very typical. If you see this kind of OCT pattern like this, and here kind of hyper reflective materials sit next to the hollow hypo-reflective material here. It's like a fluid level. You may think about this lesion. Well, I think it's quite fascinating because from the angiogram, it looks like there's a leakage. Yeah, it's not leakage, there's like a leakage of the dye into the pocket of fluid over there. But in fact, you're going to see some kind of like hypofluorescence, block hypofluorescence at the center as well. And if you look carefully, you're going to see like the fluid level here, a sharp margin that outline the pocket fluid and the yellowish material over here as well, that you can identify from the OCT. I think this is the contralateral eye of the same patients. Sometimes you're going to see this stage of this disease. This is the autofluorescence. You're going to see the ring. It looks like bull's-eye maculopathy too in the stage of this disease. And if you perform the OCT scan, you're going to see this is, I mean, how can you differentiate this from CSC? If this is not the fellow eye of this patient, if you see this patient in your clinic and the other eye is normal, you probably think this is CSC, right? How can you differentiate this from CSC? This patient is much older. The patient should be much older, right? And I think the key is you have a look at the choroid. If this is CSC, you should see a kind of thick choroid, right? But the choroid in these patients, they are normal. This is one of the feature that you can use for differentiation. And you have a look at the pocket of fluid over here. You're going to see a well circumscribed of the fluid. And you can see the line here, the well circumscribed line here, which you not probably see very often in the CSC. And here, on the angiogram, you're going to differentiate this from CSC quite easier, I think. Because you're not going to see this from CSC, right? A kind of patchy hyperpresence for the whole lesions. You may see this patchy hyperpresence in the area of leakage, but not the whole lesion. And in that phase, you're going to see this kind of like sharp border here, outlining the kind of RP abnormalities here from the first angiogram. This is a case example of the adult vitelliform lesions. And here's another example. You see the yellowish lesion around here. Here, you see the same thing, right? This is a cut from below to above. And you can see the yellowish material sit down at the lower part of the lesion. And here, you can see the dripping of the photoreceptors. So, here's the question. Is this a form of Behr's disease? You know Behr's disease, right? Whenever you say Behr's disease, it's a dystrophy, right? It's a dystrophy. And when you say dystrophy, it's a bilateral disease, and it's a genetic disease. Is it a form of Behr's disease? Yeah, maybe yes, because a proportion of these cases has autosomal mutation of the BEST1 gene as well, the same as typical Behr's disease, but that's a small proportion. You remember the slide I showed you? There's many names. Yeah, because of actually there are many causes of this condition. So you understand? So if you see a kind of yellowish material at the macula, and you see kind of typical finding on the OCT of this case, you probably see this is a kind of adult vitelliform lesions. That's kind of like overview name. But in these adult vitelliform lesions, you may have many causes. I'm going to show you the causes of this yellowish material, of this adult vitelliform lesion. So one of the causes may be, in some portion of these cases, they may have the mutation of the BEST1 gene as well. So this is the same as Behr's disease. But, well, as I say, a majority of cases are sporadic cases, and they have mutation at another site. It's not BEST1 gene, but at the IMPACT1 gene, and the IMPACT2 genes. So this is not really a Behr's disease in majority of cases. Here I'm going to show you the table which indicated the difference between adult vitelliform lesions and Behr's disease. You can see the yellow lesions in both of these diseases. Right. In terms of onset, usually these acquired lesions going to have the onset of like 40 to 60 years old, and for the Behr's disease, you're going to have the early onset of this disease before the age of 30 years old. And the size of the lesions for the acquired vitelliform lesion is usually small, but for Behr's disease, it's quite large, like a huge egg at the foveal center, right? And in terms of characteristic, the acquired vitelliform lesions, they are unilateral or bilateral and quite asymmetric. But for Behr's disease, as I mentioned earlier, this is a typical dystrophy, so they are bilateral disease. Okay. In terms of lesion, majority are only one lesion, they are solitary, but may have multiple lesions as well. And Behr's disease, they may have multiple lesions as well. EOG, this is the typical finding that you're going to use for pathognomonic for the Behr's disease, right? If you can perform EOG. It's usually abnormal for Behr's disease, but well, it's usually normal or mildly subnormal for acquired vitelliform lesions. So, but actually, in some cases, may have overlapping presentation. So you may see some patients, like 40 years old, and have the yellowish lesion. So that's kind of the patient with overlapping spectrum. So some of those patients who present to you at a younger age, but it's not really young, it's like between 40 years old, you may have mutation in BEST1 gene as well. So it's kind of variation. So mutation of BEST1 gene may be one of the causes of adult vitelliform lesion. It's one of the causes, but not majority. You understand, right? Okay. I try to get you slowly. So it is not, if majority is not Behr's dystrophy, can it be like other form of macular dystrophy? Yeah, probably yes, because I told you before, it may be associated with the other two mutations, which is a dystrophy. But, well, there are some kind of dystrophy, macular dystrophy, that looks like vitelliform lesion as well. Here are some examples, what we call pattern dystrophy. It's like butterfly dystrophy, or reticular dystrophy, or pseudoscatar dystrophy, or some others. So, and the thing is, some of these pattern dystrophy that we know for the past, they have mutation of the PH2 genes, which is the same as the adult vitelliform lesion too. And probably no, because, well, some of these adult vitelliform lesions may have some causes which is not related to genetic cause. A significant proportion of cases may be just degeneration. So this is why I think maybe, well, the term acquired vitelliform lesion may be more appropriate. I don't know, Edwin, what you think, which term?
I still use vitelliform because people understand it.
Yeah.
I still feel that vitelliform is useful. But I think acquired vitelliform degeneration or dystrophy, I don't think I will put dystrophy, because I think dystrophy connotes a genetic basis for it.
Yeah.
So it has to be acquired to make sure that we know it's degenerative, and vitelliform because of the appearance.
Yeah, yeah. If you can perform a genetic test and you can identify the gene, which I'm going to show you later on, you may call this dystrophy, but in fact you may call it vitelliform lesions, in general. It can be everything, right? But this is not macular, this is not AMD, this is not CSC, this is vitelliform lesion. Okay. Here is this is the differential diagnosis of the acquired vitelliform lesions. In fact, this kind of vitelliform lesions may be associated with macular disease, other macular disease, like dry or wet AMD, or even epithelial membrane. It may be just associated with separation of RP and photoreceptors. It's a disease unto itself. And it may be a typical Behr's disease, as I mentioned earlier. And it may be a kind of pattern macular dystrophy. And it can be like deletion is associated with systemic disease as well, as one of our friend suggested before. So here's from the textbook. This is typical finding from the textbook. You have this kind of yellowish lesion, and the thing is, well, from the angiogram, you may see it's a leakage, but it's nice to have the OCT. If you have OCT, you can see the kind of elevation of the RPE, and you can see this kind of yellowish material inside the yellowish material that you see in the fundus photography color. And you may see multiple lesions here of the vitelliform lesion as well, here and here. And here's, this is a typical vitelliform lesion, but you may see some hyperrefractive materials above it. And there's disruption of the epiphyseal zone here as well. This, and well, this is what we call the pseudo-hypopian appearance. You can see this is quite a nice autofluorescent picture of this lesion. It's much clearer than the color photo. But if you look carefully, you're going to see the kind of pseudo-hypopian appearance here. And this is quite nice as well. It may be associated with other macular abnormalities. Just like in this case, it's associated with RPED. You see the yellowish materials sit above the RPE. Actually, I've seen this patient on Saturday. There's a patient that presented to me. He's 70 years old, had a giant RPD in both eyes, only giant RPD, but he had this material sit above the RPE in both eyes. So if I can, I may pull the photos to show you later on, maybe. And well, here's typical Best disease, right? It's kind of big yellowish stuff at the macula. This is typical Best disease, very typical. And you can see this kind of yellowish material associated with the vitreomacular traction or epimacular membrane too. So it can be associated with other macular disease. And it can be associated with systemic condition. Like in this case, the patient's been treated for metastatic cutaneous melanoma, and she has this kind of vitelliform lesions in many areas. So it may be more common than you think. But well, here the kind of pattern dystrophy, a typical pattern dystrophy, it looks pretty much like adult vitelliform lesions, right? And this is other eye. This is not really looks like vitelliform lesion, but the other eye. What it looks like in terms of the OCT. And what is the yellowish lesion? So what is that? Lipofuscin. Okay. In fact, it's the outer segments of photoreceptor cells which been focusized with macrophage. And in fact, our RPE, the retinal pigment epithelium, can kind of digest all this material into the RPE. Normally, in normal situation, it can do that, but for this situation, the digestion is abnormal. So our RPE has kind of like digestive problems, like our stomachs sometimes. So it kind of leave this kind of yellowish lesion underneath the retina. So this cartoon is it's very nice. Here is the mechanism of the BEST1 gene mutation. Actually, the BEST1 gene is located within the RPE. You can see the outer segment materials usually be digested within the RPE cell, and this location of the BEST1 gene. And when it's been mutated, the outer segment materials kind of stuck into the subretinal instead of to be inside the RPE. Right. So this kind of caused the yellowish material. And here's the location of the PRPH2 genes, which is located within the outer segment of photoreceptor. It's not in the RPE as the best one gene. It's different location, but in fact, when it's mutated, it causes the same situation. It causes accumulation of the outer segment material between the RPE and the retina as well. Here. And here's another gene that may cause the mutation, the IMPEC1, which is located in the outer segment too. And instead of digesting the outer segment material, it's going to be accumulated between the outer segment and RPE as well. So we may use multimodal imaging studies to delineate this disease. We may use autofluorescence, fluorescein angiogram, ICT, or CT. However, we can use all of these together for making diagnosis. And actually, there's no typical findings of each, because there are many, many stages of this disease. Well, you can say this may be a typical finding, but this is only the early stages of this disease. As I mentioned earlier, you may see this kind of yellowish material at the lower part of the lesion, but in fact it can be at the temporal part, like in this picture. You see it's at the temporal part, not lower part. And here, these patients have the stage of like outer retina dystrophy, atrophy, It's lost photoreceptors and some outer segments. The epiphyseal zone is gone as well. You see, and this kind of left face of this lesion. You see, this looks like a GA, right? It looks like a geographic atrophy, and no other materials left. Luckily, in our case, it ended up to be like normal. RPE is not end up to be like geographic atrophy like this case. So, what kind of treatment? Then we're gonna treat these acquired vitiliform lesions. Watch and wait. So you need to, I think the thing is you need to look at the lesions carefully to rule out the neovascularization that may occur in some cases. The anti-VEGF is only helpful only when associated with neovascular AMD and CNV presents. And the visual prognosis for this condition is kind of varied, dependent on stages and associated disease, as I mentioned earlier. So if this is like associated with epimacular membrane, so if you treat the macular membrane, this kind of lesion may be gone after you peel the macular membrane. And if this lesion in the early stage, you have to follow this patient carefully if they're going to have CNV. If not, I think the visual prognosis is quite good. And here are other differential diagnoses for wet AMD. Anyone familiar with the first one? Type 1, macular neovascularization with aneurysmal dilatation. You familiar with that? You familiar with that? Anyone know what it is? Actually, it's PCV. It's PCV. It's a new name of PCV. It's a new name of PCV. You see, well, is it true? You think this name is true? If you take a look at the images of the PCV, especially from the OCT, PCV is like it's differential diagnosis of wet AMD, right? The typical wet AMD is always, right? But if you look carefully at the OCT of the PCV, you're going to have the PCV have two lesions, right? The polypoidal lesions and the branching vascular network, right? And the vascular branching network is a type 1 or type 2 or type 3 pneumovascularization? Yeah, it's type 1, right? It's type 1. So it's type 1, but the terminal valve of the type 1, this kind of type 1, have a polyp, right? Right? So actually we call it polyp, but in fact, you call it polyp, it's like, actually if you call it polyp, is it different from polyp in your intestine? Is that mucosa? Actually, when we call it polyp, it's a kind of mucosa, right? And it's not vessels. But we call it polypoidal because it looks like polyp. So in fact, it just, if you think about it carefully, well, it's possible that this kind of type 1 pneumovascularization at the terminal valve is being dilated and it forms polypoidal structures. And actually, it's an aneurysm. It makes sense? It makes sense? It makes sense? That this is a type 1 macular pneumovascularization with aneurysmal dilatation. It makes sense, right? But the name is too long. The name is too long. The name is too long. PCV is kind of, well, easy. It's easy to call, but this is kind of type 1, well, we may need a short name of this. You can think about the shorter name of this. Right?
I think we should stick with this.
You know what? Vas told me that, well, if it's wrong, why don't you stick with it?
I don't think it's wrong because we are calling it polypoidal and not polyp. So as long as we know that it does not truly reflect the histopathological appearance of a polyp, I think that's fine, so polypoidal. If we say that choroidal is wrong, then we should change choroidal neovascularization to something else, because our type 1 occult CNV is still called choroidal neovascularization. So I think it's best not to confuse everybody. That's my view.
I just want to confuse all of you today. It's PCV, but it's okay. It's stress to you that PCV contains branching vascular network, which is type 1 pneumovascularization, and well, it contains polypoidal at the terminal valve, and that's about it. So this name is going to remind you this is type 1 pneumovascularization. That's all. And I think the next differential diagnosis is probably pachychoroid neuroscleropathy. Yeah. I'm going to show you later on in the OCTA lecture that I'm going to give in the afternoon. And CSC is always masquerades for the AMD, right? And myopic, every choroidal neovascularization should be like your differential diagnosis of wet AMD, right? Especially in myopic patients, and sometimes you're going to see idiopathic choroidal neovascularization. What's the difference between idiopathic neovascularization and typical wet AMD choroidal neovascularization? What's the difference? You think what's the difference? Lucent? Yeah, okay, lucent. Lucent is better. And you think the idiopathic CNV is a variation of AMD? Actually, you're gonna make diagnosis of idiopathic CNV when you encounter much younger patients present to you, and it's not, well, they have like a typical CNV at the macula, but they're like 20 years old, or 30 years old. And well, you perform every imaging modalities, and this is not typical AMD. Yeah. And what's the main difference between idiopathic CNV and AMD? And CNV in AMD. It's a visual prognosis. I think if you treat this patient with anti-VEGF, you're going to need only 1 or 2 injections. And that's about it. And that's clear. Almost, I mean, all the cases of idiopathic CNV is very, I mean, visual prognosis is very good compared to AMD. You need to maybe treat patients like forever, like many, many years. That's one of the key difference between these two entities. Yeah. So yeah, you may have a kind of these cases. Like, well, you may have cases of wet AMD which may be presented as a fluid around here. Yeah, and the macula, and well, you may have slightly bump of the RPE here. And well, at this area, it can be like leakage, just like the typical CSC, or it can be neovascularization. This is where OCTA going to come in 2 rows. You may do the ICG, but it may not show you that much. But OCTA, I think it helps you a lot to differentiate CNV for these cases. So you need to think about acquired vitiliform lesions whenever, I mean, you see the yellowish lesions in the deep macula in the DELS. And the vitiliform lesions, I summarized for you here, it may be a true dystrophy. You may have bilateral cases, and you perform genetic testing, you may find the patient associated with mutation. The mutation that you're going to find maybe, it can be like BES1 gene as well, if the patient's age is kind of young enough. And you may find mutations of some other genes that I mentioned to you earlier. And it can be like just sporadic cases, as Edwin told you, it's just a degeneration. You didn't find anything, you didn't find mutation or anything, it's just degeneration. In terms of degeneration, it may be associated with kind of ocular disease, like the material can be on top of the RPED, which is quite common. And you may find it associated with epimacular membrane or other disease as well. And you may find it associated with systemic disease too. And it's quite common, so you should think about it. Think about it instead of just inject Avastin to all the cases. Any questions at this point?
Excuse me, sir.
Yes, please.
I'm just curious about the first case that you described.
Yeah.
How can you manage the patient? First come 2011.
Yeah.
He saw the 2020 with the symptoms, and then you evaluate for 1 year, 2012. And 2013, you finally inject. 2 times injection, and then you choose to observe patient. How can the patient keep coming to you after you say to you, oh, something wrong in your eyes? Come back to me next year. I mean, in
Oh
next year.
yeah, that's
will be just run away. I mean,
that's
something wrong in my eye.
yeah, that's a very good question. I think that's a very important point for this disease. You need to, actually this is not my case. He was referred to see me after the 3 injections doesn't work. So what I told him is that, well, you probably don't have choroidal neovascularization. Probably you don't have AMD because he's been diagnosed as AMD before. So he probably have, I just explained this disease to him. You may have this kind of acquired vitiliform lesions, which may be associated with many diseases. Just straightforward with him. And the first doctor that doing the injections doesn't have any wrongdoing because you think you may have AMD, and the standard treatment for AMD is injection. He's doing nothing wrong. This is very important when you get referred from some other doctors. The first thing is please don't blame the first doctor. It's going to cause a lot of problems. Okay. You've been treated for 3 months already, 3 injections. If you really have AMD, you really have neovascularization, there should be something changed. But there's nothing changed at all. So you may have the disease, this disease, which actually we don't have any treatment at the moment. So you may have genetic disease, or you may just have the degeneration. So luckily, his visual acuity is not too bad. Just make him understand his situation. And you may just follow him like a month later. Just, well, if you try to explain all this to a patient, you don't want to leave him, right? Just bring him closer. Maybe you explain this to him and maybe make appointment 2 weeks or 1 month. I think 1 month is enough to see if there's something changed. Just follow. So, in fact, observation is observation. It's not, observation is kind of treatment, right? Observation is not treatment. It's not no treatment. It's a kind of treatment. We close monitoring him. Just let him come a month later, and then everything is still okay. You look okay. It's still like 20, 40. Nothing changed. So just come maybe next month again. Everything's stable, and then we just make everything stable. We can extend the follow-up, right? Yeah. And later on, fortunately, well, you see, in fact, the visual prognosis is quite good. So luckily, well, all the yellowish material is kind of gone. So I don't know. Maybe his RPE is kind of like gain functions after all, and they can digest all the yellowish material after all. And then he got like 20/20 vision after that. It's interesting, very interesting. But this is the way we deal with patients. Yeah, just don't leave him. Just don't leave him. Explain everything to him, and you may need to close monitoring him. Just keep the gap between you and the patients very, very narrow. I think that's the key. Yeah. If you say like, well, you don't have the disease, the first doctors doesn't need to do any injections. You just come back like maybe 6 months. Well, you're gonna cause problem, I think. Yeah, just try to understand him and let him understand the disease. That's what I practice. Yeah.
Once the telephone material disappears, does it come back again? Is there a relapse?
Oh, that's a good question. Yeah, I think it can come back again. It can come back again. I think, yeah, this patient needs to be monitored closely. Yeah, because, well, I think his RPE doesn't function well. So, I don't know the reason why the yellowish material finally disappeared, but we need to closely monitor him. And the yellowish lesion may come back. And you still have a risk of having neovascularization in the future. So we need to close monitoring anyway.
Do these patients some of the group really have a low vision later on or not?
No, it depends.
Because one patient you showed with the geographic atrophy.
Oh yes, yeah. As I mentioned earlier, it's like there are many stages of this disease. So the visual prognosis is kind of different. And unfortunately, we still don't have any treatment of this. Still nothing to do. I think the first question is very good. So how we deal with this patient. Luckily, my case is okay. Visual acuity is very good. But for cases which is, come to you in advanced stages, where you need to maybe it's the same thing that you deal with late AMD cases, the same thing. Your vision may not be as good. So, but the thing is, I think the key for this muscular syndrome for wet AMD is the patient don't need injection. Don't need injection. You try to treat this patient, continue treating these patients. It's gonna just spend a lot of money, right? And then, well, maybe 5 more injections, nothing happened. You switch to Eylea, maybe 5 more injections, and something's gonna happen. So you need to recognize this disease because, well, there's no treatment at this point I don't know in the future, but you probably don't need to treat this patient with that expensive medications.
I had a few patients, they had
Yeah.
a problem with the contrast, not with the vision as per se.
Yeah, yeah.
The Snellen's
Yeah.
visual acuity was 20/40.
Yeah, yeah,
But the perception of the color was really bad and the contrast was
yeah, yeah.
bad. So they had a problem.
Right, right, exactly.
So we cannot do anything for that.
Unfortunately, at the moment, still like. Thanks. And well, if you want to read, this is a very good paper about this, the Dowd concept. Well, in this paper, they still use the name of dystrophy at the title, but anyway, it's very comprehensive paper, and it contains like 40 to 50 pages about this disease alone. But anyway, I think I told you, I mean, majority of what you should know about this disease already. And well, and this, some of you have registered already, right? So if not, you can still have some time to get a discount price until February next year. So this is another Asia Pacific Academy of Ophthalmology meeting. It will be here in Bangkok, 6 to 9 March. We work very hard for this, so we hope to welcome all of you here again in March next year. Okay, and any more questions? I'm very happy. I think the Q&A part is very important. Yeah. You talk about ABAO? No. Yeah. Oh yes, yeah. Yeah, yes. That's very good. Yeah. Yes, maybe that's the reason why the first doctor would like to do injections to this case. Yes, you remember or you see it? It's a kind of like intraocular cyst. And Professor Adrian told us, right, if you see intraretinal cyst, you should be aware. So they follow your rules to do injection. And curiously, well, the last picture that I show you, there's still a tiny cyst over there, but it's not, I mean, oh, okay. Here, if you look carefully, there's still a tiny cyst here. It may be just maybe a degenerative cyst, probably. Yeah, maybe, but obviously the cyst is kind of larger before the treatment. No, not this view, but it's great that you can pick that up. Yeah, yes, yeah, it's quite obvious. But in the latest picture, it's like a small, very small one. And the orientation of this cyst is not like the typical intraretinal fluid cyst. It's not a real cyst sometimes because cystoid, if it's not a real cyst. What do you think about this? Yeah.
In fact, I think most fluid compartments will be more vertically linear rather than horizontally linear. Very rarely do they first appear horizontally. So I think this is probably more degenerative rather than good. But the true test is you give an anti-VEGF and see what happens to it.
Yeah. And one of the key is, well, if it's not only applied to this case or this disease, whenever you, treat patients and it seems that he or she doesn't respond to your treatment, I think the first thing is to look back at your diagnosis first, instead of doing more treatment. I think that's a key for this case as well. Yeah. I hope this teach us some lessons. Some more questions? Yes. Okay. Yeah, we still have like 1 minute. Is that true? Yeah. Maybe one more question.
Just curious, sir.
Yeah.
What about EOG in this patient?
What?
EOG?
Oh no, we didn't do it. I'm sorry, we didn't do that.
And is it common for vitiligo disorder like this to have a spontaneous solution? Is it common?
Is I don't think it's common.
Yeah.
I don't think it's common.
Maybe it's acquired and
Yeah.
If it's dystrophy or degenerative, right?
If it's dystrophy, you're not gonna get any. It's true dystrophy, you're not gonna get any improvement. Right. Right. Yeah. Yeah. It's kind. That's what we call like. Well, it should call like degeneration. Just like I mentioned, there's maybe many causes for this, like a true dystrophy or just degeneration, or maybe just associated with other disease. I mean, the VMT, when the macula has been pulled, it may cause dysfunction of the RPE, and it may cause this yellowish material to deposit. It's possible. And if you treat the cause, the yellowish material may be gone. Yeah. Okay. That's great. Great. Okay, thank you.